Thanks very much, Christine, for inviting me. And first of all, I'd like to acknowledge the traditional people of this land and their ancestors, and particularly the children of future generations. And really, I don't think we can tell New Zealand much, because I think New Zealand is doing very well in the area of fetal alcohol spectrum disorders. And what we really need to do today is move the agenda forward and bring it to the attention of the policymakers and the politicians who can actually fund programs to make things happen. So what I'm going to do today is just give you a bit of an overview of some of the challenges that face us when we're addressing fetal alcohol spectrum disorders, and perhaps provoke a bit of interest about what might be the solutions. So I'm going to cover briefly what fetal alcohol spectrum disorders are, why we should know about them, and what are the challenges for families, professionals, governments and policymakers, and hopefully allude to some of the solutions. I'm going to give you some examples from Australia, and particularly refer to a community-led initiative in remote Western Australia, which I think demonstrates exactly what a small, motivated community can do. So, as many of you know, fetal alcohol syndrome was first described in the English literature by Ken Jones in 1973 in children born to alcoholic mothers. And to make this diagnosis, you require facial abnormalities, growth failure, either before and or after birth, and either structural abnormalities of the brain, a small brain, or structural problems to it, or functional abnormalities to the central nervous system. And by that I mean problems with motor development, speech, learning, etc. And depending on which part of the brain is affected, we can identify what might be the potential functional outcomes for children. And we can identify these characteristic facial features, particularly that thin upper lip, which you'll see on the top of these charts, and the very indistinct area, the filtrum between the bottom of the nose and the upper lip, and what we call thin, narrow palpebral fissures. That's the eye opening. Alcohol is toxic to the brain. Alcohol impairs the optic nerve development. For example, the eye is small and the eye opening is small. So these are just manifestations of alcohol exposure, and I think you can see from the children at the bottom, there's a Hispanic child, a Caucasian child and an Afro-Caribbean child, that these features hold strong. But one of the difficulties that we have in Australia, and you will also have in New Zealand, is identifying whether the normal charts that we use for these measurements are appropriate for example, Maori and Pacific Islander children and Aboriginal children. Now, since this description of fetal alcohol syndrome, we've come a long way. And in 2004, the term fetal alcohol spectrum disorders was coined, really to emphasise that fetal alcohol syndrome is just the tip of the iceberg. If children are exposed to alcohol during the first third of pregnancy, when the face and the other bodily organs are being formed, they may get facial abnormalities and birth defects. However, the brain continues to rapidly develop in the second and third trimesters. So although alcohol exposure at that time won't cause birth defects and facial abnormalities, these children may have significant neurodevelopmental problems, that is, neurodevelopmental disorder. And of course we need to remember that exposure to high levels of alcohol may also result in stillbirth, miscarriage, prematurity and other pregnancy complications. So why do we need to know about fetal alcohol spectrum disorders in Australia and New Zealand? Well, we've heard about the high risk drinking in women in both of our countries. We know that binge drinking is common in teenagers. We know that unplanned pregnancy is common. In Australia, some figures suggest 49% of pregnancies are unplanned. We know that 60 to 80% of women say that they're drinking alcohol during pregnancy, and that a proportion of these will be drinking at a very high risk level. And importantly, we need to remember that although these brain defects and birth defects are permanent, they are preventable. We touched on this morning the rights of the child, and I think we need to remember this when we're deliberating about FASD, that every child has the right to life, survival and normal development, and the health and education interventions that are required to ensure that. And specifically, the statement identifies that minority groups should not be ignored, and that includes children with disabilities and Indigenous children. So what are our challenges? Well, probably the first challenge, and this sounds a bit facetious, but is to acknowledge that fetal alcohol spectrum disorders exist, that alcohol is the cause, that it's preventable and that it has significant implications. So we've really got to get this message across, and I think we've got to get it across, as has been alluded to, in school-age children, that when a woman drinks during pregnancy, the maternal blood alcohol level rapidly equilibrates with the fetal blood alcohol level. That alcohol is poisonous to the developing brain and other organs, and that the damage will depend on the amount of alcohol ingested, the frequency, the timing during pregnancy, and a whole range of maternal and fetal characteristics, including genetics and ability to metabolise alcohol, that we can't really measure and which make predicting the risk in an individual pregnancy particularly hard. And this is why I think we need to take the precautionary principle that if you don't drink alcohol, your infant won't have a fetal alcohol spectrum disorder. The next challenge is to identify individuals, make a diagnosis, and to make this early. I saw this child at 3 years of age. He'd not previously been seen by a paediatrician. He'd been born to a 19-year-old alcohol-dependent mother, unplanned pregnancy, and the father had custody from birth. She drank on occasion 5 litres of wine per day, 1 packet of cigarettes. The baby was born preterm and low birth weight, was irritable, fed poorly, and had seizures. And as he got older, he was slow to develop speech. He had problems with his coordination and motor development. He had problems with learning. At 3, he didn't know any of his colours. He had a squint. He was emotionally labile, and he was socially inappropriate. He would readily go off with anyone he met in the park or the street. He had problems with attention and hyperactivity, was disruptive at home and in preschool, and exhibited risk-taking behaviour, climbing onto roofs, running out onto busy roads. He had particular difficulty with any complex task, and that was even a task involving 2 instructions. That is a problem with executive functioning that we see characteristically in these children and adults. He'd repeatedly repeat mistakes. So each morning he'd get dressed, putting his school clothes on top of his pyjamas, and had to be corrected each morning, and was said to be disobedient and difficult to manage at home and in preschool. And this is this dear little boy who, for no fault of his own, was born with a small head, narrow eye openings you can see, widely spaced eyes, and this very indistinct philtrum and thin upper lip. And it's easy to predict that this child may have ongoing problems, particularly through his lack of ability to be educated. Now, this will be talked about a bit later, but we do need to remember that fetal alcohol spectrum disorders are not a problem of childhood, that the problems continue into adulthood and are compounded by disrupted education. So as these children grow up, as shown by this longitudinal study of adults with fetal alcohol syndrome, they are often unemployed, have mental health problems, problems with drug and alcohol, may be imprisoned. Up to 60% in this particular study had trouble with the law or imprisonment. They have problems with sexuality, and in this study, only 10% at the age of 21 were able to live and work independently. The good news, I guess, out of this study and subsequent studies is that early identification and intervention, regardless of the specificity of that intervention, may decrease these secondary disabilities. So we do need to remember that the effect of FASD, a lifelong, cannot be reversed, and our challenge is to enable every affected child to achieve their potential and to live a happy and healthy life. It is important to make a diagnosis. If we don't make a diagnosis, we can't refer the child for assessment and treatment. If we don't make a diagnosis, we can't refer the mother for treatment of her alcohol problems, and we can't prevent the birth of potentially another affected child. And parents tell us again and again, both birth mothers and foster parents, that having a diagnosis enables them to understand their child and have realistic expectations of their potential. But making a diagnosis is not difficult. There are several different diagnostic regimes that have been promoted internationally. There are different diagnostic criteria used in different countries, and this really makes the situation very difficult. At the moment, what we're doing with a grant from our Commonwealth Department of Health and Ageing is trying to come up with what we think is an appropriate screening and diagnostic instrument for use with fetal alcohol spectrum disorders in Australia. The other challenge we have is to document the size of the problem, because if we don't know that a problem exists, we can't advocate for services, policy, etc. There are virtually no population-based studies anywhere in the world, certainly none in Australia and New Zealand. We need some data. We've heard that prevalence estimates range from 1 to 5% of children, but we know that this might be much higher in high-risk settings, such as remote Aboriginal communities, such as in Cape Province in South Africa, where we know the rates are really high, up around 88 per 1,000 births. We did attempt to get some information about newly diagnosed cases of fetal alcohol syndrome in Australia using the Australian Paediatric Surveillance Unit, where all paediatricians in the country report to this unit every month and tell us whether or not they've seen a newly diagnosed case. Now, we were able to confirm that there were cases out there. We found 92 new cases of fetal alcohol syndrome in the 4-year period, that these kids characteristically had low birth weight, were preterm, had small heads because of their brain damage, that few of them were diagnosed early, only 7% at birth. We also identified that a lot of these kids were Indigenous children and that 60% were in foster care. And this, of course, inhibits the diagnosis, because often when you have a child in foster care, you don't have access to those, well, to either the mother to give a history or to those early pregnancy notes. And what was most distressing in this Australian study was that 51% of the children reported to us also had a sibling with fetal alcohol syndrome. When you consider this as a lifelong problem and that it's been estimated that one child would cost, health costs alone will be millions and millions of dollars, this is really a problem that we must prevent. And yet in this study we were only dealing with the extreme end, we felt, of the tip of the iceberg. That is, 92% of these kids had high risk exposure to alcohol, and interestingly 75% of them were exposed to one or more drugs in addition to alcohol. But when we actually did the figures, the birth prevalence was extremely low, much lower than reported in the States, in Africa, etc. And we asked the question, why? And I'm just going to show you a few little bits from a health professional survey that we did in Western Australia. These results are from over 600 health professionals who saw women in pregnancy, and you can see there on the right-hand bar that less than half routinely ask about alcohol use in pregnancy, and in fact 12% don't ask at all, some of them believing that they'll anger or frighten the mother if they ask about alcohol use. Women tell us an entirely different story. We've recently done a survey of a representative sample of women of childbearing age, and over 95% say they want to be asked, they want to be advised what to do, and furthermore they want to be advised not to drink during pregnancy. So women want to do whatever they can to ensure a healthy pregnancy, and I think we can't be too precious about feeling that we might, we shouldn't be asking those difficult questions. We also asked health professionals what they knew about the diagnostic features, and this is just for fetal alcohol syndrome, which is much more clear-cut than neurodevelopmental disorder. And you can see that although about half knew of some of the features, only 12% knew of all the diagnostic features. So this is another barrier to diagnosis. Many of them said they wanted resources for themselves and their family. Many of them, a significant proportion, 60% plus, said that they were afraid of making the diagnosis because they were afraid of stigmatising children and families. Others said, what was the point in making a diagnosis when there was nowhere to refer these children for confirmation and when there was no specific treatment available? So there are a lot of barriers to actually making the diagnosis. So another challenge we have then is to educate health and other professionals and to hopefully change knowledge, attitudes and skills. And when I say other professionals, teachers have to be involved, the justice system, disability and community services. So following our surveys, we developed a series of educational materials, and these should be available at the Telethon Institute for Child Health site, which I've put there. And then we redid our survey, and reassuringly, following the survey, health professionals and paediatricians specifically said they felt more able to deal with a child with fetal alcohol syndrome. They felt more knowledgeable about how to make the diagnosis, where to refer the child, and most importantly, more of them were asking about alcohol use and advising not to use in pregnancy. I've got 10 minutes here, Christine, is that right? Yeah. The next challenge is to develop multidisciplinary diagnostic services to allow early intervention. And when Liz Paedon, a student of mine, did this survey back in 2008, there were no clinics on the right side of the world. There is now a pilot clinic in Sydney in Australia. I don't know what the situation is in New Zealand, but many of these clinics are funded on soft money, and we really need to get those services going. There is uncertainty about how to treat. Liz Paedon again did a systematic review, and although she found nearly 6,000 articles on fetal alcohol spectrum disorders, there were only 8 randomised controlled trials. They were poor methodologically and had very poor numbers. So we're really waiting for some CDC-funded studies to get some answers about what treatments might work. We need to understand what might influence women's knowledge and attitudes. Again, Liz Paedon, as part of her PhD, did a survey of women of childbearing age. And although 81% said that women shouldn't drink alcohol during pregnancy, only about 80% had a negative attitude when presented with a scenario of a pregnant woman drinking in a pub. So 21% have a tolerant attitude to drinking alcohol during pregnancy. 35% of them, even though many of them were well educated, said they were unaware of the adverse effects of alcohol on the fetus. And when we asked them, did they intend to drink in a future pregnancy, we found that intention to drink was not associated with knowledge or education, it was associated with attitude. So we really have a lot of work to do in our prevention policy, not just to inform people, but as we've been discussing this morning, to change community attitudes to alcohol use in pregnancy and to consider some of these other features such as partners' use of alcohol, smoking behaviour, etc., which also are aligned with intention to drink alcohol. And of course we need to remember that other groups may have different attitudes and behaviour in relation to alcohol use in pregnancy. So for example, in this work we've done in Indigenous people, we need to understand why Aboriginal women drink. And this is all associated, as we were discussing this morning, with the social and economic context, that these women may be unemployed, uneducated, suffering domestic violence, they've lost traditional land and culture, they may be families of the stolen generation, they need to travel 500 kilometres to have their babies. We need to look at public health issues, policy, taxation, pricing, limiting access. There's been an application for labelling, and you may have heard recently in December of 2011, the ANZ Ministerial Council acknowledged the need to put labels on alcoholic beverages. We need to make sure those labels are evidence-based, are big, are visible, and give a very clear message about drinking during pregnancy. We need to restrict advertising. This advertisement aimed at young women of low-calorie vodka cruises advertised the offer of free condoms and the chance to win a pole dancing set if you bought this alcohol. So if that doesn't align young women with alcohol and with sexual activity, I'm not sure what does. And you may have heard in Australia that there's been an increased tax put on alcohol pops for the young. And this has had an effect in the amount that's being bought. It may have been transferred to other types of alcohol, so we've really got to ensure that taxation is alcohol-wide. If we're going to have public health policy, it needs to be adequately disseminated to the population and to health professionals. When we did a previous survey of health professionals, only 13% of our health professionals gave information consistent with our national health guidelines. Recently, the Foundation for Alcohol Research and Education identified that 95% of young people couldn't identify safe drinking levels, which were advocated in the updated 2009 guideline. And I think frighteningly, in particular, people between the age of 14 and 19, young men said it was safe to drink 8.8 drinks on an occasion and women 6.5 drinks on an occasion, when the guidelines recommend that to minimise risk of harm on a short-term harm, 4 drinks should be the maximum. But our biggest challenge is prevention, And that really involves research, resources, attitudinal change, public health policy, legislation, community awareness, availability of diagnostic services, etc. So what I want to do just very briefly in my last 5 minutes, Christine, if that's okay, is to give you an example of a community that's taken the issue of fetal alcohol spectrum disorders into its own hands and report to you a bit on the Little One Project, a community-led initiative in Western Australia. Now you can see the dot on the left is where I come from in Sydney. The dot on the right is Fitzroy Crossing, which is about 500 kilometres inland from Broome, so up to 18 hours from Sydney. And this is a collaboration between 2 Indigenous organisations and 2 research units in Sydney, the University of Sydney and the George Institute. So back in 2007, there was an inquiry into alcohol use in the Fitzroy Valley. Many people were dying young people were dying from suicide and alcohol-related injuries and violence, and the women said something must change. They lobbied the Western Australian Licensing Board for restrictions on the takeaway of full-strength alcohol, and this was later evaluated and found to have had a significant effect on reducing alcohol-related hospital admissions, violence, increasing school attendance and decreasing the amount of total alcohol sales in this particular remote valley. A film was made of these alcohol restrictions, and the women of the community were invited to present this at the United Nations, where they got a standing ovation for their work. June Oscar, one of the women who initiated these restrictions, said recently in Parliament, FASD is a tragedy that somehow transcends other aspects of grief and trauma. Here is innocent young life, the future of our people and all that goes with it, our culture, our language, knowledge about the magic creation and laws of our country, being born into this world with brains and nervous systems that are so impaired that life for that person from birth to death is cruelly diminished. So when they came back from the UN, they said, we've really got to address the issue of fetal alcohol spectrum disorders, and developed a strategy to address supporting parents, preventing FASD and diagnosing FASD. And in 2009, we were invited to help them in this endeavour by conducting a prevalence study, population-based prevalence study in the Fitzroy Valley. It's predominantly Aboriginal people living in 45 very remote discrete communities and belonging to 5 different language groups. These are the investigators, our PhD student James Fitzpatrick, June and Maureen, and Jane and myself. And we spent the whole of 2010 going around these communities and interviewing mothers, getting detailed information, including antenatal exposures. As you can see, there's not accommodation in most of these places, so we had to camp along the way. And we had to develop our own tools, so we photographed locally available alcohol so that we could get accurate information on alcohol intake. And then we scored using the Audit C, which is recommended for use in pregnancy. And this is just a summary of the data. About half these women didn't drink or drank at very low risk during pregnancy. About half did drink, and you could see that from that 3% drank at a moderately risky level, 45% at a very risky level. But if you take just the half who drank, 93% of women who drank did so at very risky levels. And by this I mean 10, 12 plus drinks per day during pregnancy. In 2011, last year, we took a multidisciplinary team and we spent a year up in these communities doing a full health and developmental assessment of all the children whose parents we'd interviewed the year before. And you can see some of these assessments going on. And we've identified that these kids have significant service needs. They have needs for neurodevelopmental clinics, they have hearing problems, community health problems, problems with severe dental caries, and 40% of them required referral to the psychologist or the child and adolescent mental health service. The community has been praised for standing up and addressing this issue, and the Aboriginal and Torres Strait Islander Health Commission has commended this as a genuine partnership, one where research is done with, not just about, Aboriginal people. To raise awareness, we have made another film called Tristan, which is going to be launched at the United Nations this year in May at the Forum for Indigenous Issues. And the Governor-General, who visited the project last year, is also going to have a launch of this film in April of this year at Admiralty House in Sydney. We've brought in educators so that we're not just taking away data during this study, but we're educating the community about the harms of alcohol use during pregnancy. We've educated local people in research methods. So these local people with local language skills broker every relationship between the researchers and the community, and you can see they're looking very happy there with their new tents. We've reinforced the community-led restrictions on takeaway alcohol, and also subsequently some of these communities have become totally dry communities by law, and we're supporting that. And just to note that this has been a real collaborative effort between a whole range of organisations. We've had input from, for example, advertising agencies who've helped us raise money, and we are now delighted that the House of Representatives have launched an inquiry into fetal alcohol spectrum disorders and invited our group and others to make a contribution to that inquiry about the prevention and management of fetal alcohol spectrum disorders. So thank you very much for your attention, and I'd like to acknowledge all my collaborators and funders in these efforts.